First, I'm Dr. Chen. I'm the one of the leadership member of our group, and also SMIDA. Dr. Guangton is also one of our leadership. So here we, on behalf of our team, and really being very thankful for Beck Institution is willing to provide this free lecture for our team members, and it's a very useful tool in the CBT to help us to provide a service and peer support to our colleagues around the country. And especially thank Dr. Miller is willing to provide us this lecture in such a short period of time. So Dr. Miller is a director of the CBT program at the Beck Institute. And he has a lot of experience, both administratively and also clinically. And he also has a lot of teaching experience. He personally participated into a lot of these crisis intervention. And I think he is a great resource for us to learn from and to get the necessary skill to implement it in our current project to help our colleagues at the front line around the country. So, so I pass on to you, Dr. Miller. Thanks a lot.
Thank you very much, Dr. Chang. I'm very happy to be here, and welcome to all of you to this presentation titled CBT for Frontline Medical Professionals, Brief Interventions During a Time of Crisis. The first thing that I want to do is commend all of you for volunteering your time to participate in the very worthwhile work that you're going to do in supporting your colleagues on the front lines. My hat is off to you, and I am very happy to be able to be able to contribute a small part to helping you in the work that you're doing. I wanted to mention that in addition to me, Beck staff members Rachel, Grace, and Caroline are on the line in case you have any technical issues or if you have question and answer kinds of things. I wanted to start off by telling you that the night before last I had a nightmare. And the nightmare was this, that this webinar was scheduled for 2 days. And I was in a panic about how I was going to fit everything in 2 days. During the first day of the workshop, in my dream, I actually fell asleep while I was talking, and I inadvertently put on a video of animation that had nothing to do with the topic that we're talking about. When I woke up, you were all very forgiving, and I very much appreciate that. But let's all hope that in this case, my dream does not come true. What I would like to do for, my screen is frozen. There we are. For those of you who don't know, I just want to mention that CBT is based upon the seminal work that was done by Dr. Aaron Beck in the 1960s at the University of Pennsylvania. Then in 1994, Dr. Beck and his daughter, Dr. Judith Beck, established the Beck Institute. I had the privilege of being a trainee at the Beck Institute from 1994 to 1996. Since that time, I've been a lot of places. I have used CBT in a lot of different situations for a variety of different patient populations. And indeed, it's an honor for me to be here and to be a part of the Institute at this point. The Institute, as you know, is a leading international source for information about cognitive behavior therapy. Beck Institute itself has the mission to improve lives worldwide through excellence in cognitive behavior therapy. And indeed, the presentation today is one of the things that allows us to further that mission. And I greatly appreciate the participation of all of you who are here on this call today in order for us to do it. Should you wish to have more information about Beck Institute, you may do that by going to our website. And you may also register, if you wish, to get our free newsletter, which is at beckinstitute.org. Subscribe. So with that said, I want to get right into the presentation for today. There are a number of different things that I want to present to you. Some things by explanation in the beginning, and then later on just identifying what and when you can use different types of techniques. So the first thing is to talk about the situation itself and to talk about the importance of clarification of values of those people that you will be working with on the line. I want to talk about the CBT model as it applies in crisis intervention. The cornerstone of cognitive behavior therapy is cognitive conceptualization, and we'll briefly cover conceptualization of depression, anxiety, and anger, and then get into some more specific kinds of techniques like cost-benefit analysis, the Socratic questions, which are keystone to cognitive behavior therapy. Other kinds of things that come from the tradition of dialectic behavior therapy, distress tolerance, emotion regulation, and then getting into things like sleep hygiene, monitoring activities and planning activities, the importance of relaxation and mindfulness, interpersonal effectiveness, and also to talk a little bit about hopelessness. And then to wrap it up, talking about action plans. I have a lot of information and a lot of slides here, which I don't expect to be able to cover entirely during the amount of time that I have to talk with you today. But what I wanted to do was put them on the slides, and we can make the slides available to anybody who is interested in having them after the presentation is completed. So for the beginning part of the presentation, I'm going to push as much information as I can toward you, and then we will stop because I'm told that there will be lots of questions that you will have, and I look forward to having the opportunity to interact with you about any questions that you do have about how to apply CBT in crisis situations. So the situation itself, as it stands right now, as described by the American Medical Association, is that it's common to experience increased levels of distress during a crisis, especially because of social isolation. And I have to tell you this, I cringe every time I see and hear the word social isolation used right now, because it has become a policy that social isolation is something that we should try to accomplish. It may be splitting a hair, but it's really important to me to think about physical isolation as the thing we want to accomplish. But isolation is the last thing that we want to have happen. We want people to be together as much as they possibly can using technology that's available and any other means, because collegiality and support is truly the thing that will get us all through this. But one of the additional things is that frontline medical professionals strive to strike a balance between their professional obligations and their concerns about themselves, their family, and their friends. I wanted to point out something that might help you to work when working with them to clarify their values is an article that is going to be in tomorrow's editions of the New York Times Magazine. I provided a link for you here, and you can go directly to that after you get the link and the PowerPoint presentation. But this is something that I think presents a lot of really interesting ideas and the dilemmas that people have, and the ethicist helps people to think through how to make good decisions or the right decisions for each of them as individuals. So what are some of the stressors that people have when working on the front lines? Volumes and acuity, the possibility of infection, long shifts, inability to save all the patients, shortness of supplies, underpreparedness, and separation from partners and families. So some of the normal adjustment issues So what do I say? Normal adjustment, because anybody in this situation would be likely to have these kinds of adjustment issues. So at this point in the early stages, when somebody is still in the stressful situation, we would say that it's normal for them to experience any one or a number of these: being overwhelmed, feeling fear, feeling guilt, frustration, anger, of course, just being physically exhausted. Substance use is something that often occurs, and certainly feeling lonely and missing social interaction and opportunities. So what are common goals? Usually first on the list is people say they want to try to get control of their lives. I put a link there to a blog that I wrote during the past week about getting control and how the pursuit of getting control can sometimes and in some ways sabotage one's own interests. So the link is there, and you can read about that separately if you wish to do so. But resolving ethical concerns, reducing fear, lowering anxiety, limiting anger, and making some healthy lifestyle changes. So what is the CBT model for crisis intervention? Keep in mind that these things are listed, but they're not linear. They come in different sequences, and sometimes people go back and forth. So one of the first things that we hope to do is, as much as possible, provide for the physical needs, the safety, and establish as many social connections as possible. Using CBT, we try to conceptualize or formulate what is causing the problem and what is maintaining the problem for the person. We try to elicit from individuals their values so that we can use their values and their aspirations as the guide for what is going to be the way that we set priorities, do problem solving, and establish other goals. We want to teach people how to cope with the stress that they're living under, but also to make change for those things that they do have control over. We want to, the challenges that they have, how do I or a colleague of mine get in the way? So we want to help them to understand what it is that they are doing and what they can change in order to make their adjustment more adaptable for them. And finally, acceptance, and that is, especially in an environment like this, there are many things that we do not have control over. And when it comes down to it, we have to accept it, and it is what it is. Common CBT values: we want to demonstrate understanding toward the people that we're working with. We want to listen, we want to empathize, and we want to demonstrate interpersonal effectiveness by showing unconditional acceptance for the people that we're working with. We want to develop our conceptualization, as I mentioned, and normally we try to focus on one issue at a time so it doesn't get confused, and so that we can develop plans and outcomes for each individual thing. And we work in a very collaborative fashion, meaning that there's a lot of back and forth interaction between the people that we're trying to help and ourselves. So a long list of techniques that we use, and I'll just talk about those as we go along. I want to start with cognitive conceptualizations. And those of you, I'm told that most of you have had some training in cognitive behavior therapy, and so you will recognize this as the conceptualization model that was originally developed by Dr. Beck in working with depression. So there's a situation, there's an automatic thought about that situation, and then the reaction ensues. And so therefore, the automatic thought serves as an intermediary between the thing causing the stress and the person's reaction to it. So this goes back to the original idea that it isn't the thing itself, but our thought, our thinking about that thing that leads to the reactions that we have. So first of all, depression. This is the original model, again, developed by Dr. Beck for depression: the situation, the automatic thought, and reactions. Their intermediate beliefs and core beliefs certainly oftentimes in crisis situations, and especially the situation that you're going to be getting into, oftentimes maybe interacting only one time with people, there isn't going to be as much opportunity to get into the other beliefs, intermediate and the core beliefs, but certainly there will be some opportunity to talk about the automatic thoughts that they're having. And here are examples of some of those thoughts. I can't do my job. I can't be in my own house. I miss my family. There's no end in sight. The situation is hopeless. So those are the kinds of things that often come up in situations like this. Now, the anxiety model is a little bit different. With depression, normally what we're doing is reacting to something that has already happened. With anxiety, what we're doing is anticipating poor performance in something that hasn't yet come. So we anticipate that there's danger ahead and that we are unprepared for it. And when we consider ourselves and when we say to ourselves, we're not prepared, we don't have what it takes to deal with this, how do you think that that impacts our performance? Well, generally it makes our performance suboptimal. And so it becomes a kind of a vicious cycle where we're predicting a negative outcome. And then because of our actions, we do get less than an optimal outcome, which increases our anxiety. Here are some of the things. I might get infected, I could get sick or die. There are too many cases, I can't handle the workload. The acuity is too high. I can't give cases the attention that they need. My patients might die. Anger is something that is very, very common, and I've simplified the cognitive model for crisis situations here. So the way that I explain it in crisis situation is that there's an incident that occurs, which is a representation of disrespect. When we feel disrespected, the emotion that we most often experience with that is one of hurt. And the disrespect when the disrespect comes about as a result of a violation of a rule, then we think that somebody is to blame. And when we think that somebody is to blame, that's the thing that actually triggers the anger. So again, instead of the incident itself, it's after we believe that we've been disrespected, and when we believe that somebody else is to blame for it, we feel angry, and then we're likely to act out in some appropriate or inappropriate way. Common thoughts about anger are, this isn't fair, I don't deserve this, they knew this was coming, we don't have enough PPE, there are no ventilators, we're running out of meds, they lie to us. So those are things that are examples. I want to give an example of each of those: anger, anxiety, and depression. So when you're hearing those kinds of words, these are things that you can use even in a one-session model to begin to formulate your conceptualization about what is going on with a person, because we don't have the luxury of spending an hour to do a case conceptualization. And so these are to help to give you a boost in that formulation about what is going on with a person. Oftentimes in crisis situations, people need to make decisions. So after they've established their values, after you have some kind of formulation about what it is, we review the advantages and disadvantages. We do this in an analysis, and we oftentimes do a full 4-cell chart, so that when somebody is saying, what would be the advantages of me to, for instance, staying in the medical profession? What would be the advantages to me if I stay in the profession? What would be the disadvantages to me if I stay in the profession? But also, very importantly, what are the advantages to me if I don't stay in the profession? And then, of course, what are the disadvantages to me if I don't stay in the profession? So we think about all of those kinds of things in terms of helping people to make important decisions. Here's a shortcut way of getting to it, an acronym of ITCH for problem solving. We identify a problem, we think about all the possible solutions, we choose one of those solutions, and then we implement it and then assess how well does this work. So I'm clicking through different kinds of techniques that you can use with people with different kinds of problems, because they're going to come at you in all different ways, all different times, from person to person. So Socratic questions, again, a keystone of the cognitive model. The important thing is what we're trying to achieve is a cognitive shift. A person has distortions or an unbalanced way of thinking, and what we're going to help them to do is get a slight shift in the way that they're thinking about things, so that when they change the way that they're thinking about things, their mood and their actions also will be changing. So what is the evidence that my thought is true? What is the evidence that my thought is not true? What's an alternative explanation for this viewpoint? What's the worst thing that could happen, and how would I cope with it if it did? Sometimes the worst thing does happen. So what's worse than the worst thing happening is having the worst thing happen and having not thought through how you're going to cope with it and how you're going to deal with it. So we can help people prepare for the worst by helping them to develop a coping strategy for when that does happen. Of course, we also ask the question, what's the best possible thing that could happen for you? And of course, what's the most likely thing that's going to happen, which is usually someplace in between the two. Socratic questions for guided discovery. What is the effect of myself telling myself repeatedly this same thing? What could be the effect of changing my thinking? What would I tell someone else if they viewed this situation in this way? What should I do now? Distress tolerance is something that comes directly out of the DBT tradition, and it's an acknowledgement of the facts of the situation and realistic limitations. It doesn't mean that we approve of it or that we're resigned to it, and it is not anti-change. In fact, it is a prerequisite for change. It's very similar to the serenity prayer, to ask for the serenity to accept what I cannot change, the courage to change the things I can, and the wisdom to know the difference. Interestingly and importantly, when somebody begins moving into the acceptance mode, it's often accompanied by sadness and guilt. If you're talking to somebody who is expressing sadness and guilt, it probably means that they've begun moving into the acceptance mode, and that by itself has some negative emotions that go with it. A wise mind accepts, an acronym and a technique from the DBT tradition. So once accepting, there are many other things that we can do to distract ourselves from those things that we're concerned about, that we're worried about, and they allow us to remove ourselves from the situation mentally so that we don't continue to experience the distress, and that is laid out for you there. Emotion regulation is one of the things that many people say is most important to them, because their moods are up and down and around and all over the place. Again, coming from a DBT tradition, one of the things that's really interesting and important is that the things that are most helpful coming out of that is to establish routines and healthy eating, exercise, and sleep. So I know that sleep is one of the problems that is most commonly identified by people who are in very stressful situations. So I'm just going to give you the formula for sleep hygiene that you can share with people. You're likely to get pushback on some of these things because we get pushback on these things. Nevertheless, I've treated people who have had insomnia for many years. In my experience, many people who have insomnia for many years, if they follow the simple directions for sleep hygiene, they actually begin to sleep much better. Some people, a small percentage of people don't, and we get into more advanced techniques then that we don't have time to talk about in this presentation today. But avoiding stimulants and depressants both. Lighten up on evening meals and exercise a few hours before. But here's the crux of it. Go to bed at the same time every night, get up at the same time every day. People working different schedules have trouble with that. And so it's true, we have to make accommodations as best as we can to try to adhere to the directions as much as possible. People following most of the directions are still likely to have a better outcome in terms of sleep than if they don't follow any of them. Having a quiet place, keeping the bedroom dark and cool, dedicating your bed to sleep and sex. Interestingly, I've talked to many people about sex, and the amount of time they spend having sex isn't enough to interrupt their sleep, so that's not a problem. But we don't want them watching TV, eating, playing cards, working on Facebook, those kinds of things. Turn off all screens 30 minutes before bed, turn off your phone, and limit daytime naps. Activity monitoring, so people, especially with depression, will feel sluggish and have trouble getting about. So one of the first things we do is ask people to keep track of their actual level of activity and monitor that for a week. And then after monitoring it for a week, turning it into a schedule, so that when they find places where they have voids in their schedule, or where they find themselves doing things that they find unproductive or that don't make them feel good, then we want them to put things in there that will give them a sense of mastery or accomplishment and or a sense of enjoyment. So if you're only seeing somebody one time, you can still give them the direction to keep track of their activities for a week and see where the voids are, and then to put in the new activities for the week after that. Certainly, with levels of stress, the benefits of relaxation are, I think, well known, so I'm not going to describe them. Even though they're well known, some people, my hardest patients, have not been willing to do relaxation exercises. And so this is one that even the hardest patient I think that I've ever had, who refused, in terms of refusing to do relaxation exercises, actually recently agreed to do this one. So I'm trying to sell this one pretty hard, a 1-minute breathing exercise. You breathe in deeply, 6 seconds, breathe out for 2 seconds. Actually, I'm going to change this because that first one should say 4 seconds. You breathe in for 4 seconds, hold it for 2 seconds, breathe out, exhale for 6 seconds. You should exhale slightly longer than inhale. If you do that 4 times in 1 minute, our research indicates that it will reduce heart rate and it will reduce blood pressure just by doing that one thing for 1 minute. Mindfulness is paying attention in a particular way, in a present moment, in a non-judgmental way. And you see this throughout the CBT field. So it's training your attention, and it's focusing exercises. You can read about that, and I provided here an example. This is one of the most popular and well-known. It's an exercise, leaves on a stream, and 1 through 9 tell you the actual steps, so you can guide somebody through that, or you can just give this to somebody to use as an example. Another thing that I often do with both relaxation and mindfulness exercises is I record them as I'm demonstrating them, and then let the person that I'm working with record it and take it with them so that they can use that at a later time. So now, especially for people who are angry, because it's absolutely true that some of the situations that frontline workers have been asked to work in are deplorable, in the sense that they don't have PPE, that they don't have enough people, that they're overwhelmed, and they're not given the kind of guidance and so or support that they need. And so in situations like that, what is really important is that people understand that they have legitimate rights, and that they have ways that they can and that they should stand up for their rights. Another acronym from the DBT model, Dear Man. So it describes the situation and walks you through each step of that, of what you can do to express yourself. In one session with someone, you can walk them through step by step. You can do a little role play with them. You can have them imagine how they're going to use this when they're going to talk to the person that they need to talk to. And you can even set it up as a little experiment. How did this work out? And make the necessary modifications. So CBT for suicide prevention is a bit beyond this presentation. I'm assuming that you all have lots of experience with that. And so I'm not going to repeat that. But for one of the things about suicidality, or even depression with hopelessness without the suicidality, there are a couple of things from the CBT model for suicide prevention that I think are useful using just for the hopelessness aspect of things. And one is developing a safety plan, whether or not, or even if somebody is posing a mild risk. I think it's helpful to have contact people, resources available, to have their names, their phone numbers, their texting contact information available so that you can use that. The other thing is a hope box, a really, really nice thing. So when we think about hopelessness as being one of the most difficult challenges that people have, and moving into sometimes thinking about or having suicidal thoughts, a hope box contains pictures, it has inspirational quotes, it has humor, it has anything that really gives a person a reason to want to continue to live. And a hope box used to be something that really appeared in a shoebox. Today, more often, people put it on their laptops and their phones and things like that. So it's more accessible. They have pictures of things and places. So the next thing, and this is really getting into the end of a session that we would have with someone. When in CBT, before somebody leaves our room, we want them to have some kind of plan. We don't expect that we're going to solve everything or decide everything in the one session that we have with them, or even if we're seeing them every week, we don't think that we're going to best use the time in that 1 hour. That time will be better used if they have something to use, to practice after they leave. So it's going to encourage people to use the thing we talked about in the session after the session is over. You know, common action plans are using coping skills, evaluating thoughts, using coping cards, completing an activity log, using breathing, calling a family member, using communication skills, implementing a decision. Most of these things we've talked about in the past few minutes. So we generate action plans. They're tailor-made for the individual that we're talking to, for the problem or issue that we're working on today. And one of the things that we do are coping cards, and coping cards are used for three things. One is an automatic thought. What would be a more adaptive things? Remember back at the beginning, for anxiety, for instance, one of the examples of an automatic thought is, I'm afraid that I'm going to get infected. What would be, if after we think about all the possible things, what would be maybe a more accurate one? Well, if I utilize all the PPE that is at my disposal, then I have a really good chance of being able to do this work without getting infected. So we would write that down on a card or a phone or something like that. We try to encourage coping strategies. So when I'm feeling stressed, I can do a breathing exercise or a mindfulness exercise or a reminder, why am I doing this? And this ties back to the values. This becomes the real motivator. Why am I doing what I'm doing? I've made a decision, I'm going forward, and to remind me about what my values are is, I mentioned imagery. So one of the things that we do when we ask people to go out and to practice something like role playing, we ask them to imagine it before they go and do it so that they can see themselves doing it and being successful at it and being able to enjoy the success that they have. Continuing with imagery there, and then behavioral experiments are things that we work out. So lots of times when I get resistance from people, when we're talking about an action plan, they'll say, well, that's not going to work anyway. What I immediately fall back to is say, you know, honestly, I don't know if it will work for you or not. How about if we set it up as an experiment? Just go out, try it, and let's see what the outcome of that is. See what goes well, see what doesn't go well, and then afterwards you can assess the outcome and make your adjustments and then proceed forward from that point. And those are the behavioral experiments. We provide the rationale, we develop a prediction about it working, and then we record the outcome. And then the last thing is we assess the likelihood. We ask somebody on a scale of 0 to 100, how likely is it that you're going to complete this plan? And anything less than 90% is really in the questionable category. So we want to redesign the plan until the person we're working with is able to say, with 90% certainty, I will do this when I leave. So those are a bunch of different CBT techniques that I have found very useful to use in crisis situations of all sorts. The last slide here just provides a summary of all of the things that we just covered, and I'm not going to read them to you because they will be there for you to read. And I'm going to bring to a slowdown now, the part of my pushing information out to you, and I welcome your questions at this point.
Dr. Miller, Smita Gautam here.
Hello.
Hi, can you, okay, I'm gonna start my video. Can someone on the admin side open my video, please? Thank you. Thank you so much for such a great talk and so many useful tips.
Thank you.
I know it's a difficult topic and a lot of information to crunch, and you like from 11, like I'm on Central Time, 11:10 to 11:40, 30 minutes to the dot. That's great. I have a question from one of our volunteer psychiatrists, and an important question, so I'll start with that.
Okay.
The part that is challenging to me is there is a likelihood that those on the front line can get infected and may die. How do we help with that? It is a realistic fear.
Yeah, it is a realistic fear. And coming from a CBT perspective, we never dismiss reality. We don't ever pretend like the threat is less than it is. And so I would say that what we do is help the person first to work with their values and make decisions about what they want to do. Remember, ultimately, it is the individual physician's decision to work on the front lines or to not work on the front lines. One of the things that we can create problems for ourselves with is when we take on the responsibility of making them to feel good about their decision or being able to make the decision for them. Our task is to help them to decide, yes, the risks are real. This could happen. In spite of that, or in some cases because of that, what is it that you want to do? What is most important to you? I'll refer back also to the first slide, the article, The Ethicist. I would recommend that you read that, because that talks a lot about this issue that physicians need to make and the choices that they need to make. Ultimately, what we need to do is relieve ourselves of the responsibility and help them, give them all of the information that they have to make the decision themselves for what they want to do. It is absolutely not our place to try to talk them into it, or even to say you've made the right decision, because we don't know. When people come to me, they say to me, you're the expert, you tell me what I should do. I say to them, I'm an expert in CBT, but I honestly and firmly believe that you are the expert in knowing what is the best thing for you. And so if we work together, I'll add the CBT to it, you contribute what you know is best for you, and together we'll collaborate and try to come up with the best possible plan for you. Did that answer the question, or is there a follow-up to that?
I think there is a follow-up to that.
Okay.
So you talked about values and sort of ground that, dilemma into values. Can you say a little bit about how to elicit values in a smaller, like a 15-minute phone call, or how do we go about it? Oh,
yeah, sure. So, if we were in a workshop, this would be one of the things that I would love to role play with you. But since we can't do that, what I will do is I'm going to talk to you. I'm going to do my part of the role play, even though I don't know exactly what the responses are. But so I would start off by saying, this is obviously a very, very difficult decision. And it causes you a great deal of distress. And I'm really sorry that you've been placed in a situation where you have to make these kinds of decisions. In some ways, it's intolerable. I'm wondering if it would be okay with you if we talk about what would be the best thing for you, given that you have concerns about your family, and you have obligations to work. Would it be okay with you if we talk through the possible outcomes of all of those? I'm going to stop that role play right now, and then from there, knowing that we only have 15 minutes to talk, instead of talking about value, I've identified, if you will, the cognitive dissonance about choosing between the two and the relative merits. So without going into a long session about it, then I would use Socratic questions to say, what do you see as the downside? We could use a cost-benefit analysis. What do you see as the advantages of disadvantages? Because this is a real possibility. And then based upon their decision, about whether or not they decide that they want to remove themselves from the situation or whether they want to go back into the situation. They've accepted responsibility for that. And then we use the Socratic questioning and the cost-benefit analysis to help them to think it through and for them to feel okay about the decision that they have made. And then we reinforce their ability to make a decision.
That's useful. Thank you. So rather than going into eliciting values, in that moment, we are doing advantages and disadvantages of the two options.
That's right. That's right. We assume that the values are there and we make a reference to the values, but in a short video call like you would have here, you don't have the luxury of the time to talk about their life values. We just sort of say, this is your choice, and you've already made it, you have to make some kind of decision about your values and which one are you going to prioritize. It's a very, very, very difficult decision for them and very, very difficult work for you to do to help them to get to that point in just a few minutes.
I'm going to read out a question. I'm not sure if I understand it well. It's from Dr. Cheng. And Dr. Cheng, if you want, you could unmute yourself. Imagine being one of our volunteers on the shift and getting a call from an ER physician, working with limited supply of PPE, facing overwhelming volume of COVID patients, feeling burnout and fear of contracting the disease himself, especially in the context of hearing the recent news of an ER doc dying from COVID in just few days. or passing it on to the family. How would you handle a scenario like that as a volunteer?
Oh, good. I'm glad we're starting with the easy questions. So what I'm going to do is the first thing that comes to my mind is the technique, the short version of ITCH, which I included in here. So we're going to say, what is the problem? The problem is that the person is in a very threatening situation. So then I'm going to say, what do you see as your options? You can just go back, not say anything to anybody. You could walk out the front door. You could go to an administrator. You could do any one of a number of things. What do you see as the whole list of options that you have? Okay, from that list, choose one of those things. Go back, give that a try, see how that works, whatever it is. If you decide to walk out the front door, you know, an hour later, how do you feel about that? Or if you decide to go back without talking to anybody, how is that working out for you? Or they say, well, I need to talk to an administrator. You could go directly to the interpersonal effectiveness and the dear man technique to use the assertiveness to speak up and say, look, you're putting us out in the front lines, you're putting us in danger, and you need to provide us with the supplies that we need to provide this care. So take your pick, which one do you do, and then afterwards, see how, if you feel okay about it and don't need to talk anymore, that's great. If you want to talk more after trying that, please feel free to give us a call back.
There is a follow-up to that. There are people that feel that they do not have a choice, but feel like they're forced to work with few or no PPE. What would you say to a situation like that?
Yeah, so again, this is another really difficult kind of question. What I'm going to do is remind all of us that in a situation like this, we are not the ones who can make a decision for other people. You know, I've managed a lot of crisis situations over the course of my career. One of the things that I've learned, I have a short list of lessons learned. And one of the lessons that I've learned is I don't have to know the answer to everything. And in all humility, I don't know the answer to most things. So we don't have to know the answer. What we have to do in this case is use Socratic questions to help them to decide what is the right thing for them. I do not feel that I am capable, and I would not want anyone listening to think that you should make that decision or even give advice. You can think about, well, if you feel like you're being forced, what do you think would happen if you said, no, I'm not going to go? And then we could ask the Socratic question, if you make that decision, what is the worst thing that's going to happen to you? I'm going to get fired if I walk out. Okay, so if you get fired, what kind of plan can we work on helping you to put into place in case that happens? Okay, then then we could do that. So I'm going to go back to work and I'm going to get sick and I'm going to die. Okay. So sensitively, I want to ask the question or acknowledge that that is a possibility that you will die. If you were to get sick and become terminal with this illness, what are the things that you could do to make the best out of the amount of time that you have left to live? How are we going to improve the quality of that? So again, they decide, and then we help them to develop a plan for how to live with the decision that they make.
So I am guessing there are a couple follow-ups to this.
Okay.
At the moment, even the idea that this may happen and they will die, and to develop a plan, some physicians might have come to that point where when they are really seriously thinking that this may happen to them. But others might have a reaction to that verbalization from our side. How would you engage them while they are like having a distressing reaction? Like they're not even ready to engage with this intellectually.
Yeah. So good question. So I was going off of the wording that I used. So
Yeah.
I was using that wording, assuming that it was already put out there. So if a physician doesn't say, I'm afraid I'm going to die, or that that's a possibility, I'm not going to offer that to them. I'm going to say, what do you think is the worst that could happen here? And then I'm going to use whatever words they give me rather than plant the idea that they're going to die. That's an excellent question.
And there is a sort of opposite question to that.
Okay.
That came from one of our doctors. I'm not sure that the frontline folks are at a point where they recognize that continuing work is actually a choice. Financially, they may feel trapped and also have such guilt about the idea of leaving. If they are not expressing that they are even aware that they can do anything other than continuing to work, how do we broach the idea that they even have a choice? Like that
So rather than use the word choice, and rather than get into it and go at it that way, in that kind of situation, what I would be more inclined to do is say, first of all, empathize with them and reflect that empathy as much as I can, that you're really in a difficult situation here, that you're really forced, like you need to do this. So with that, it sounds like there isn't any choice or any decision to be made. So rather than posing it that way, we would use a Socratic question to say, how do you see this playing out? If you continue to do what you're doing, how do you see it playing out? What do you see as the possible outcomes of this? Or do you see that there is any other thing that you can do in this situation? So when I'm doing the presentation like this to professionals who understand the language, I will use words like values and choices and things like that. Most times when I'm working with somebody who is really struggling, I'm going to use the words that they use most often, so that I don't plant the seed for something that they're not even worried about at this point. Okay? Okay,
sounds good. Thank you. So just to summarize, if people are not aware that they do have choices, if you want to get them there, then ask the question, how the Socratic method, how do you see this playing out? What do you think will happen if you continue with what you are doing right now?
That's right.
We have few minutes, so I'm going to ask two more.
Two more easy questions? Great.
So it sounds, so two things. One is about anticipatory grief. People are experiencing some anticipatory grief, and how to work with that, how to address that during a call. Two, how to get somebody to acceptance of a current situation in the quickest way possible. But I remember the Serenity prayer is a great way, I know, but go ahead.
As quick as possible. We'll first go into a time warp.
Yeah.
Okay. So, I'm sorry.
Anticipatory grief.
I lost the question. What was the first one? I'm sorry.
Anticipatory grief.
Oh, anticipatory grief. That's right. So that I'm going to feel sad and bad about the fact that people under my care might die. Is that the situation? See, so the first thing I would do is clarify, what is it that they're anticipating grief about? So again, we put it on.
So they're not anticipating grief. It's a way the questioner asked.
Okay.
They are feeling grief, and the grief is about the possibility that either they will die, their patient will die, their family will die.
Oh, okay. That somebody will. I'm sorry. I just want to clarify one more. When I think about somebody dying and it being, and I'm feeling responsible for it, are we sure we're not talking about guilt as opposed to grief?
We may use both then, the guilt as well as grief.
Well, sure. Keep it simple. So, all right. So the first thing about guilt, because we really do have short time now, I guess. So regarding the guilt, so we're going to use questioning as much as possible to take them through the decision-making, the processes and the procedures that they've used, the degree to which they have made the best possible use of the resources at their, and what I might do in a situation like that. They're saying that I've done all of that, but I still feel responsible. What we sometimes do for such occasions is to do a role play, or to have them role play, or have them imagine that they're giving advice to a friend of theirs who has just been through this. What would they say to a friend of theirs who, you know, is in exactly their situation? And I would say that I don't know if I've ever had a time when somebody is much easier on their friends than they are on themselves. So we let them use the advice that they would give to their friends and apply that advice to themselves. So I would say that for guilt, I think you know, as far as grieving the losses, well, if somebody does die, or if somebody gets infected, or if something happens, I would then go back, what's the worst that could happen here? What's the best? And then play it out. And if the worst does happen, what will be a plan that you could put into place to work through it?
And then the third question was acceptance, and the easiest way to get to acceptance.
Okay, and what is it that that we're accepting? There are many different things we've talked about. What are we trying to accept?
That the situation is grim, and we may have really bad outcomes.
Well, because that's true. It is really grim, and there have been lots of outcomes. How much of that do you as an individual have control over? I mean, things have happened in China, in Italy, all around the world. Things are happening here in the United States right now. There's no question that the situation has become dire. How much of that do we have control over? And so we would go through some questions about that, and then come back to what is it that you have control over? So I have control over whether or not I use the equipment, whether or not I take the precautions, whether or not I'm following all of the recommendations that are incumbent upon me as a frontline physician, or am I following the recommendations of the CDC when I'm off in my personal life? Am I doing everything that I reasonably can do? Am I complying with everything as reasonably as I can under the circumstances to produce the best possible results? So what we would ask a person to do is go through and answer those kinds of questions for themselves. We don't tell them, well, you're doing everything that you can and that you should do, so just don't feel guilty, don't go there. We don't tell people those kinds of things. We guide them through the process of helping them to draw the conclusions themselves, and then help them to live with the decisions that they make.
I think we are out of time, but I have 2 more questions. If you have time, we can continue, otherwise we'll wrap up.
I have time. I'm happy to take the questions.
Thank you so much. So,
unless they're too hard.
So this is not an easy question. Let's see. Recommendations in managing our own countertransference in the ethical dilemma here. So the volunteer psychiatrists, they also have feelings about failure to protect the federal to institutional level failure to protect the frontline society, the frontline and the society. And if that's brought up, we all are also physicians, and that's why this is peer-to-peer, because we understand what exactly this means. How do we monitor, modulate our own countertransference? And this is not countertransference towards the caller, but towards the system that the caller is working with.
Yeah, toward the unresponsive system.
Yeah.
So a couple of things. Many of you probably already know this and do this, but when you're working in crisis situations, this becomes more important than ever. And that is that you take care of yourselves in terms of your eating, your activity level, your sleep, and that you do the things that will regulate your own emotions. These are lifestyle kinds of things first. It's important that when you're working in situations like this, that you take breaks, that you don't overexpose yourself. It's important that you have some kind of support peer group established, and that you talk among yourselves about the different kinds of things that you're dealing with, and that you have a place where you can go to express your own anger and dissatisfaction with the system, with the government, with anybody. And as much as possible, what I would ask you to do is then, when you sit down at your desk to take your next hour of calls, that as much as possible, you try to set those things aside. And one of the things that is most helpful to me when I'm working with patients is that instead of thinking about how the situation is affecting me at that moment, I try as much as possible to focus my attention on what are the things that are going on with the person that I'm talking to. And this fits in very closely with the humanistic model and the client-centered mode. And that is, as much as possible, what I want to do is to try to understand things from the person that I'm talking to, from their perspective, and to understand why this is a problem from their perspective. Now, we're all human beings, and we all can do that with varying degrees of success from moment to moment and person to person. We have to give ourselves a break. You know, we're human too. We're not machines, and we don't click ourselves on and off like we can click our computers on and off. And so I think that in working in crisis situations, a certain amount of that kind of countertransference is something that you should expect. And so it isn't so much as telling ourselves that we shouldn't have it, as much as it is, how am I going to deal with it when it does happen, and work out a plan for ourselves in that way.
So sort of a follow-up to that, is it possible for the volunteers, can the volunteers help the callers when the volunteers themselves don't know how to reconcile those very thoughts that the callers are having, that the volunteers don't know how to reconcile those themselves?
Yeah, absolutely. Now, nothing about this is easy. But again, keeping in mind that our focus is on helping other people to process their emotions, identify their values, make decisions, and utilize techniques that will be helpful to them. We're not going into crisis situations to resolve our own issues. It just isn't the job description. This may sound harsh. Not everybody is cut out for doing crisis intervention work. I have worked on large disasters, been deployed with the Red Cross and private organizations. And almost every time I go to some large incident, there is a certain component of the medical staff, psychologists, other people who really can't function in that setting. They're just not made out for that. And certainly that's no judgment on them as a person or on their skills. It's just that this kind of work is just too overwhelming for some people. And if it is, I think it's absolutely acceptable and even advisable to say, I'm going to call it quits on this. This job is not for me. There are many ways that I know how to help people. I'm going to go do that. So I think that you know, I think that that's the essence of it. Not everybody is cut out to do this. And if that's true for you, then there are many other ways to make yourself helpful. But if that isn't it, even for those of us who do this kind of work, we still have to do a lot of things to take care of ourselves, and we have to ramp up our usual level of taking care of ourselves to a higher level in order to do this. So I'll end this with one really stupid thing that I did to this end, thinking that I had. So I was in Louisiana responding to Hurricane Katrina a number of years ago. What a lot of people don't know is after Katrina went through, about a week later, another hurricane came through. And I was there, and I was at this Red Cross shelter with, I don't know how many hundreds of people, and they were all scared because another hurricane was coming. And I said, well, okay, we'll stay here all night with you for when this. So we did that, and the other hurricane was minor, and there was no damage, and everybody was fine. So after I got off my 24-hour shift, I said, well, I have to take care of myself now. So I went out to a local track and decided to go for a 10-mile run in the 100-degree heat. Well, you can only imagine how that played out. So sometimes we don't make good decisions for ourselves, even when we have the best of intentions and hope for doing so. So give yourself a break. You're human. We're all in this, and we support one another, and that's the way we'll get through it.
Thank you.
Yeah.
One more question.
Sure.
Any guidance on how to talk to clinicians, physicians who distrust the CDC and the WHO because of the conflicting guidelines that are out there? As you know, that CDC has talked about even using cloth mask, and there are so many other scientific literature out there that it's at the most will prevent droplet, but not. And so in a setting like a hospital, it's next to nothing, but there are a lot of there's conflicting guidance about this. How to talk with somebody like that.
Yeah. So again, I think that we all hear things that will rub us the wrong way, or that we just don't trust and we think is inaccurate information. Again, we have to take a step back. We have to think about what parts of this do I have control over and what parts do I not have control over. I don't have any control over what the CDC says or what they don't say. I have my own thoughts and beliefs about what is appropriate ways and the most helpful ways to protect myself, to protect other people. So what I have under my control are the things that I do and what I recommend to other people. And beyond that, I don't have control. Now, if that's something that we really have trouble sitting with, it would be perfectly appropriate for a physician or a group of physicians to write to the CDC, or if you want to write to whomever, publicly or privately, and say, at the same time that we might respect the best intentions of the CDC or whoever else is saying this stuff, in our own clinical experience, some of the things that they're saying are not accurate, and our experience would tell us that these are the things that are going to be most appropriate. So we're going to the interpersonal effectiveness, we're going to the assertiveness technique now to make sure when we think that it's necessary and important that we get other information out there. Again, keeping in mind what is within my sphere of control and what is outside of that.
Sounds good. One more question about if, are there things we could do that could make the trauma worse? Is debriefing more traumatizing? And so generally on our calls, we are not recommending exploring the trauma. It's not a therapy session, it's a peer support line. Yeah. But I would like your thoughts as well.
Yes, I actually agree with that. So this goes back to some of the seminal work that was done by Edna Foa a number of years ago. That really addressed this issue about should we encourage people to talk about the traumas that they have incurred. And if I'm remembering correctly, what she did was randomly assign two groups of women who had been raped. And in one of those groups, their therapists were encouraging their patients or requiring their patients to talk about the trauma that they had incurred. In the other group, there was no kind of pressure or encouragement whatsoever. And at the end, the women who were not pressured into talking about their trauma not only did better than the other group, in the other group, those women who had been pressured to talk about something that they weren't ready to talk about, in some cases, were worse off than they were in the beginning. So I think it's pretty sound advice to say that we don't want to try to force or encourage to talk about things that they're not ready to talk about. And especially in a case like this, you know, for those techniques that we use to encourage people to write narratives, or where we're talking about exposure treatment or things like that, those are in situations that are post-trauma. This is after they're already safe. This is after, you know, there is some space and distance between the trauma and the person. But the people that you're working with are people who are still in the stressful situation. There isn't that kind of space. And so I would say that there is some possibility that trying to get people to focus on the trauma and talk about it, I think that there is some potential to do harm by trying to get them to talk about things that they're not ready to talk about.
Thank you. And this would be the last question, and I have taken 20 extra minutes from you. Thank you so much for that.
And I think for about the last 5 questions, you said there's one more. I can only tell you that I'm flattered that that you are continue to ask questions, and if people are still on the line, it flatters me. So go for it.
There are 54 people still on the line. So last question. A lot of people, a lot of the callers come from two-physician families and are worried more about partner dying or exposing other families who may be more vulnerable. How do we help them through those thoughts? Your answer may be some skills that are repetition, but I really want people to hear that. Two-physician families.
Two physicians in the family, yes, of course. It's very difficult. I would say, I think the first thing that needs to happen is a conversation between those two physicians about how they're thinking about everything, about what they think is important, about perhaps making decisions that one will work, one in that setting, the other one won't, or both will, or both don't. So what we're talking about again is helping people to, first of all, deal with that ethical dilemma between occupational obligations and responsibility and concern to family and oneself, and using a Socratic process to think that through. I would use cost-benefit analysis. And it might take more than one set of analyses to go through this because we're considering different scenarios. So I might do a cost-benefit analysis on each different scenario and see what we learn from that. From starting with the values, then making some kind of decision, then using simple problem solving and planning. If this is the decision that we've made, what are the plans that we need to put into place to make sure that this plan plays out as much as possible in a way that we want it to do. I think that's what comes to mind at this point. Obviously, I've greatly simplified how easy it is for two physicians to decide, okay, you do this, I'll do that, and we'll be on our happy way. But I think that utilizing all of the things that we've been talking about here, everything from distress tolerance to using breathing exercises to help to manage the level of stress, through Socratic questionings, to using all of the different techniques. I think that any one of them might be appropriate in any one of the situations or questions that you've asked about. And then for others, they may not apply, or they may not be helpful. And then in other situations, they all apply. So that's really the important thing, I think, about doing the conceptualization, and that is understanding what contributes to the dilemma in the first place in terms of the way that people are thinking about things. And so what's contributing to it, what is maintaining it, and then helping people to get to the decision and developing a plan to follow through.
Thank you, Dr. Miller. And as you rightly said, this is difficult work. And not everybody might be cut out for it, or not every day might be cut out for it for our callers. And in some way, all the techniques and the Socratic method that you're talking about do apply to us too, the callers. I think we have to come to our own acceptance and our own problem solving too before we can guide others through it. And that it's not going to be a one-time thing. It's going to continue almost every 4 days, 7 days. We'll have to revisit it.
Yeah. And
that's an important internal work to do alongside helping other callers.
And I did think that that's very insightful of you to recognize that that is part of the role that you play, and that is taking care of yourself in that way. You know, when people are first come to Beck Institute, learning how to do cognitive behavior therapy in the first place, we often start off with the essentials, and that is, how do we identify our automatic thoughts, and how do we evaluate our thoughts? And we usually recommend that people do that for themselves first before they even take it to their patients, just so that they have a comfort, a familiarity, and a feel for it before we take it to the patients. But also, we know that when we use those things, it's much more helpful to us than if we don't.
Mm-hmm.
So very insightful. Thank you.
Thank you for your time, and thank you for the extra time. I'll pass this, hand this over to Dr. Cheng.
Okay.
Hey, Dr. Miller, thanks a lot for taking, so much time, extra time to help us. So we greatly appreciate on behalf of our team. And, especially you prepared such a comprehensive talk in such a short period of time. We greatly appreciate. And, there's a lot of our team members did not have chance to attend. And I also appreciate that you agree. And Beck Institute agreed to put that material on your website so we'll be able to access it later on. Again, it's a very, very informative and a comprehensive talk. We greatly appreciate your expert. I do think that will, give us more tool to help our colleagues working on the front line. Thanks a lot.
Very kind of you to say that. It's my great personal pleasure, and I know that this was very important to Beck Institute for us to be able to sponsor this and put this on, because you are all volunteering of your time and doing something that's very noble and honorable. And any way in which we can contribute to help to make this easier for you, then we're certainly very honored to be able to be a part of this. We wish you the best of luck in all of your endeavors, and certainly if there's any way that we can be helpful to you going forward, please let us know.
All right. Thanks a lot.
Okay. Thank you very kindly. Okay. Bye-bye.
All right. Take care.